I work at Icahn School of Medicine in Mount Sinai, and also I'm an adjunct assistant professor at Weill Cornell Medical College, where we integrated and developed this program. I am going to talk about today group and family-based cognitive behavioral therapy for youth at risk for psychosis. And I will first describe what prodromal phase is, what type of symptoms adolescents and young adults are experiencing, also how we can identify these patients and how we can assess them to see if they are at risk or they are already experiencing a psychotic episode. I will then describe you group and family CBT program, and I will describe a treatment model and results of our open trial and some preliminary results from our randomized control trial. I will also talk about training program we have for clinicians to teach them how to implement and develop this program, and also talk a little bit about our future research plans. I will talk for about an hour, and we will then open this for questions and discussions, and any questions and suggestions are very welcome. So early intervention is very important. Early intervention could potentially improve the course of future illness in any disorder, and also potentially prevent the development of illness. And this is true also for schizophrenia. If we look at stages of development of schizophrenia and other psychotic disorders, we usually talk about several phases. The first is premorbid, and then prodromal, where patients might start developing some functional difficulties and start having low level, low intensity and frequency symptoms, and we call it prodromal phase. And early onset of psychosis that usually happens around age of 20, and what studies show that unfortunately very often these patients who develop psychosis are not easily identified, and their treatment is often delayed. In the United States, usually delayed for 1 or 3 years, which is a critical period of adolescents and young adults development, because this is the time when people develop social skills, also take on new roles, occupational roles. So this is a very, very important developmental period. And the question became, can we intervene earlier? Can we already identify adolescents and young adults who are developing prodromal symptoms and try to provide them skills that could possibly either delay psychosis or in some cases maybe prevent it? So what are the symptoms of, we call it at-risk mental state? Adolescents and young adults commonly experience increased difficulties at school, at work, And very commonly we see withdrawal from friends and family, isolation. Also difficulties concentrating or thinking clearly. Very common is suspiciousness and growing mistrust of others. They might experience some perceptual difficulties, for example, changes in the way things look or sound, some odd thinking or behavior, and also emotional difficulties, emotional outbursts, or sometimes lack of emotion, as well as poor personal hygiene. On the next slide, you can see it is 16-item prodromal questionnaire called PQ16. This is a very brief screening questionnaire which could help us um, identify which adolescents and young adult might be potentially at risk of developing psychosis. It's a very simple questionnaire to implement. It's only 16 questions and it usually takes 1 minute. However, this is a screening questionnaire, so we cannot make a diagnosis based on this questionnaire. But it's a helpful tool, and usually if people say yes on 5 of the items of the 16, we might want to further evaluate them. There have been developed several structured interviews. One is called SIPS, Structured Interview for Prodromal Syndromes, developed here in the United States at Yale, and also comprehensive assessment of at-risk mental states called CARMS. That's been originally developed in Australia and very widely used in Europe, and now has been also used here in United States. In our program, we have been using CARMS because CARMS gives makes it possible not just identify uh, symptoms, but also rate the level of stress associated with the symptoms, which is very important. When we talk about prodrome, we usually talk about 3 syndromes. One is attenuated positive symptom syndrome, when patient experiencing a low level frequency and intensity attenuated psychotic symptoms, such as hearing voices that are sometimes not fully formed, or having delusional-like beliefs, for example, becoming paranoid and thinking that somebody is against them, but then able to evaluate this and dismiss these beliefs. So it's a kind of like coming and going stressful level of delusional like beliefs. Also, brief intermittent psychotic syndrome, when patients would experience um, psychotic symptoms, but the duration of this psychotic episode might be not more than 1 week, and they will spontaneously recover. And another syndrome is called genetic risk plus deterioration syndrome, when there is a genetic risk in a family, so somebody first-degree relatives would have psychotic illness plus difficulty functioning. So adolescents and young adults who would experience some such syndromes could be further evaluated, and These are the patients that we recruit in our prodromal CBT program. So we have been using cognitive behavioral therapy to help adolescents at risk for psychosis. So why cognitive behavioral therapy? We know that cognitive behavioral therapy has demonstrated effectiveness and is considered an evidence-based treatment for psychosis, so for psychotic symptoms. We see a reduction of psychotic symptoms. We also see a reduction of associated distress, also reduction in functional impairment. CBT is also very helpful for non-specific emotional problems such as depression or anxiety. And also CBT been used in a population that have substance abuse problems. CBT can teach skills and specifically focus on improving reasoning strategies and also helping people reduce cognitive biases. CBT also teaches coping strategies that could protect people from environmental stressors and teaching how to deal with environmental stressors. So CBT is also not invasive, it has no side effects, and it could be potentially a good intervention to also help patients who are not already experiencing full-blown psychosis but at risk for developing such. So we developed a program called Group and Family-Based Cognitive Behavioral Therapy for use at high risk for psychosis. And this is an article where we described the program itself and also results of our open trial, which are encouraging. And I am going to talk a little bit about the program and how it works. So this is a group program, and this program was built upon our earlier group program, which was called Cognitive Behavioral Therapy for Paranoia. So this was a study for patients who have already developed paranoid delusions and suffered from schizophrenia or schizoaffective disorder. We had encouraging results from this. There was a randomized control trial in both decrease of psychotic symptoms, but also patient showed increased insight, decrease in cognitive biases. For example, they learned how not to jump to conclusions. And we also learned from this study that younger age was significantly marginally associated with more improvements. And that encouraged us to adapt this program for younger individuals and particularly to youth at risk for psychosis. So here is a program, CBT for the prevention of paranoia, but also other delusions and other symptoms at risk. So we adapted a paranoia-focused CBT for younger individuals. In our open trial, we had ages from 16 to 21. Right now, we have an ongoing randomized control trial, and we increased the age. Right now, we have adolescents and young adults from age 12 to 25. And we are right now comparing this intervention with monitoring, where we assess young individuals every 4 months. and we also looked at genetic potential biomarkers as well. This program is funded, it was originally funded by my Career Development Award from NIH, and it is currently funded by Sydney Bear Foundation, which is actually in Missouri. So originated in Missouri, and this is actually our connection to your state, which is really nice to be talking with clinics in Missouri again. So how does this program work? This program is based on research on how patients, people form delusional beliefs, and particularly paranoid beliefs, since one of the early symptoms is suspiciousness and also isolation. So we particularly focusing on these symptoms. So we put together all the research on cognitive factors that contribute into the formation of delusional beliefs, suspiciousness and paranoid beliefs, and also affect regulation and isolation, which plays a very big role. So in terms of cognitive biases, we thought that it would be important to teach young individuals of how to process information more effectively and develop better reasoning strategies as well as insight. And there's, since people who tend to develop delusions also tend to isolate, and there is a disruption in social feedback system, because the more they isolate, the more they spend time in stressful delusional thinking. They don't share this information or their thoughts with other people, so they don't get any feedback from others, which increases the possibility of increasing these paranoid beliefs and increasing the conviction in such. And also they might have social skills deficit if they spend most of the time isolating. So we thought that it would be very important to break this isolation, and that's why we thought of teaching adolescents and young adults the skills in a group format, where they can be also supported by other group members and feel not alone. We also thought that environment at home is another very, very important factor, since studies show that positive environment at home can be protective from developing symptoms, and also parents and family members sometimes are lost and not sure how to help their loved ones. So giving family members skills of how they can reinforce CBT that patients learn in therapy, as well as help themselves to have more positive and helpful attitude, we thought would be very important. And therefore, our treatment model includes three components. The first is group CBT skills for adolescents, which consist of 15 CBT lessons. And we usually have 3 to 6 adolescents in a group. Adolescents also get individual CBT, where can personalize skills that are learned in a group format. And also we have a group for family members where family members learn the same skills as adolescents are learning, but also they learn how to speak with adolescents more effectively by using CBT skills. So we adapted our program that was originally developed for clinicians to teach clinicians CBT skills. We adapted it for family members to teach family members how to effectively use CBT with their adolescents. So basically like how to be a CBT therapist in their own home environment. So our family members attend a group which is also 15 weeks, 1 hour a week, 15 lessons for family members. What do they learn? Here is a short description of CBT skills groups for adolescents and family members. They have 10 lessons where they learn about cognitive behavioral therapy. They identify their personal goals and they learn then specific skills how to identify and correct cognitive biases, and I will give you an example in a minute. Also how to um, identify their core beliefs to see which beliefs are helpful for them, which are not helpful, and can we potentially change unhelpful thoughts and beliefs. And learning how to reevaluate beliefs step by step and how to have the best judgments in any particular situations. And then also very importantly, we talk a lot in a group about how to support each other. And so another goal is to create very helpful, supportive environment where adolescents learn how to give each other a positive feedback and how to support each other, and then they work on collaboratively helping other group members reach their goals and reality test their suspicious or stressful, unhelpful beliefs. And I will also give a lot of positive feedback in the end of the group as well. We talk about how each person in a group contributed to other group members and also review skills that they learned in a group. This treatment is based on theoretical models, in particular on how to teach a concept of thinking, how to teach thinking skills, which is based on learning and instruction theory taken from mathematics, so how to think effectively. For example, when solving mathematical tasks. So I adapted it to teach adolescents how to effectively think about any problems, and also integrated fuzzy trace theory by Dr. Valerie Arena. And this theory is particularly focused on how to help adolescents develop new helpful gist. Gist is a bottom line, a meaning of information, and this meaning is important when people are making decisions. For example, if a person has an approach that things will eventually work out and be okay, they would tend to make decisions based on this rather optimistic and more secure approach. So that was another theory that contributed in how we developed this treatment. So I'm going to show you some examples so you have some impression how this treatment works. So our patients have their own workbooks, and information is also presented on a PowerPoint, and you are going to now see some of the examples from the actual sessions. So cognitive behavioral therapy for the prevention of paranoia uh, for people at risk. So each session will start with welcoming to our group, and we will use a lot of get to know each other exercises. For example, this is one of them. Please say your name, share one negative belief that you recently changed into a positive one. So each lesson would have exercises of this sort in the beginning. Patients would identify their goals for this group and would also identify suspicious beliefs or thoughts that are interfering with their particular goals. Here is an example of personal goals that group members share that patients in one group have identified. Let me tell you a little bit what they are. So here are some examples. So goals shared by group members, by adolescents. Not to have bad thoughts control my decisions, to learn healthy coping skills and implement them in my daily life, to be more social and pick good and supportive friends, to change my suspicious belief that will prevent me from being successful, to stop being pessimistic, to be more confident in myself, not to be afraid of the future. And here are more specific examples. To gain techniques that help me ignore the paranoid thoughts, to be able to get through this dark storm that I've been facing for the past year and to get back my life back essentially. A lot of these adolescents in our program, they are very withdrawn, they're in home education because they're basically afraid to be in school, and one of our goals was actually to get them, help them to get back on track and to return to school and return to their activities. And here is another example. And my goal is to be the social butterfly I used to be, just like this character Usaki in Sailor Moon, who makes friends so easily, and the friends that she makes, she knows she can trust them with her life, and I want to find friends like that. And these some of the goals that family members identified. I want to develop the skills I need to help my daughter cope with her fear of rejection and the thought that people are saying bad things about her. To have more trust in my daughter that she can achieve her goals. To have more positive interactions with my daughter. A lot of family members actually expressed difficulties and not knowing how to approach their children. And here are some examples of interfering beliefs identified by adolescents. It's just the fear of people talking about me and the fear that it's going to carry over or whatever in the college. And I really don't want that to happen. I want a fresh start and everything. Another example, interfering beliefs. I cannot learn. Another belief, nothing will come out of me. And here are some interfering beliefs that a family members identified. The things that happened to my daughter might happen to her again and cause more distress later on. I feel helpless. I won't be able to help my son. When she thinks someone is after her, some imaginary being is after her, I fall into that fear with her. So I want to learn how not to fall into her fear so I can have good support for her. I fear that she will think that I don't really believe her, that I don't believe what she is going through. So this is some of the examples that family members identified. So how do we learn? Um, we were hoping to create a very positive group atmosphere and experience, and a lot of learning takes place through games. For example, here is one example. Here we are going to learn how to distinguish feelings from thoughts and going to play a game. We have a lot of examples and we have some characters in the workbook. This is Mary. Mary is one of the characters, and she has the suspicious paranoid beliefs, and we use her example to teach adolescents how to reevaluate stressful suspicious thoughts step by step. Here is an example. Mary saw two women passing by and they were laughing, and Mary thought, they are laughing at me. We learn how to build ABC model. ABC is like an essential, basic model used in cognitive behavioral therapy. We have um, event or experience, we call it antecedent A, and here is antecedent, women are laughing, and Mary is thinking, which is B, stands for beliefs and automatic thoughts, women were laughing at me. And C are consequences of beliefs or thoughts. And so consequences, we're usually talking about emotional and behavioral. So she feels sad, she feels angry, and she left the store. And we're also here talking about Mary's core beliefs, deeply ingrained beliefs about herself. So she's inadequate. She thinks she's inadequate. And she has a cognitive bias. Whatever is happening, she tends to personalize. So she thinks it's about her. So we build ABC model of her belief. It's about me. And here is an example how we would teach adolescents about personalization bias. To give a definition what it is, so thinking that most of the things that other people do or say relates to you. And we have an example that Mary um, can personalize things, but she can also not personalize things. For example, Mary came back home and her window was broken, and she took it personally, used personalization bias. What could she be thinking? And what if she does not use personalization bias? What could she be thinking? So examples like that. And also we are teaching adolescents how to generate alternative explanation for events. Mary came back home and her window was broken. What could have happened? And then to reevaluate which explanations is more reasonable and adaptive. Here is more examples. Here is another example, an exercise how we would teach adolescents not to jump to conclusions. So we will show a part of the picture and we would ask what that might be and how certain you are in your answer. Um, so somebody might say, well, that looks like reading glasses. And we would say, okay, how certain are you? And what we know from studies that people who tend to have delusional beliefs also tend to jump to conclusions very quickly. So a person might say, I already decided. Yeah, I'm sure that will be reading classes. And then we will ask other people what do they think and how certain they are and if they would like more information. And some would like more information, which we can give, and each time we ask if they decided and how certain they are in their answer, and we provide more information. We keep asking whether they want more information, and some people do, and that becomes a car. And then we have a discussion about how this decision was made, what was helpful about it, and usually group concludes that it is beneficial to look for more information before making a decision. They also learn how to re-evaluate beliefs step by step. We first look at the belief, we look at what is negative about this belief or what is positive about these beliefs, any advantages or disadvantages. And then we go back and build our ABC model of these beliefs. We look at red flags, cognitive biases, for example, jumping to conclusions, personalizing, etc. We look for alternative explanations for this experience and evidence for and against it, and then we evaluate which explanations has more evidence to support it, and based on the evidence, how would you modify the original belief? And here it is, women were telling jokes. So I'm going to now give you a little bit of an introduction on how we teach family members cognitive behavioral skills. So family members, they have the same manual as adolescents, but also in addition, we teach them specific skills that would hopefully help them to communicate with their adolescents. And we use examples demonstrating how to do it and how not to do it. So these are all cognitive behavioral therapy skills that they are learning. And this is adapted from how we teach clinicians how to use CBT for psychosis skills. Let me give you a couple of examples. For example, recognizing, identifying, and stating emotions, what to do. We give them a definition of what it is, an example, and then what not to do. Here is some additional example. How to normalize cognitive processes. Help your adolescents to realize that their conclusion makes sense considering the information they had available. So how to do it and how not to do it. Encouraging an alternative explanation. Encourage your adolescent to consider the possibility of an alternative explanation. Here is an example. And how not to do it. So we teach them the skills by explanation and showing them examples. In addition, we have also video demonstration. This is me in the role of the mom, and this is an actor, Michael Jacobs, who helps us, and we have video examples demonstrating the skills. In addition, we then ask our family members, parents, to try these skills out. We do a role play with an actor. For 1 or 2 minutes, we have scripts that we can use, and they also bring their own difficult situations that we role play. And they get feedback from myself, from the actor, and also from the rest of the group. And family members find it very helpful. Here is an example of a situation for a parent of, we call it Scott Smith. And this is a situation presented for a family member, and they are asked to engage with Scott in a conversation and show empathy and concern and to be as helpful as possible. And then we discuss any challenges that were there and give a parent a positive feedback first, always, what did they do well, and then also help them to implement the skills that we are learning. So I wanted to talk a little bit about the results of our pilot trial. We had adolescents ages 16-21. All of them met Karen's criteria for at-risk mental state and had family member who wanted to participate. Exclusion criteria were learning disability for the study and also organic impairment known to affect the brain, and also current substance abuse and using currently also substances in the last 4 weeks. This is our recruitment flyer that explains the study. We distribute it through our clinics, and we get referrals from our clinic at Mount Sinai and also from other clinics in New York City. We did a very careful assessment. We assessed everybody with CARMS. We also used structured clinical interviews, SKIT, and we also had a number of symptom rating scales. We very carefully assessed functioning. We assessed the information processing style, specifically cognitive biases, and we also looked at therapeutic alliance, group cohesiveness, and we looked at also parent, family members learning cognitive behavioral therapy skills, and we did it by conducting role plays with an actor prior and after treatment, as well as at follow-up. So this was a very encouraging results. After the intervention and in follow-up, none of at-risk adolescents met at-risk criteria any longer. Because we had decrease in CARMS symptoms and increase in functioning. It was very encouraging. All these adolescents who participated, they went back to school and so had significant improvements in functioning. We mostly focused on positive symptoms such as suspiciousness, paranoia, but we also had a very significant improvement in negative symptoms, which was very encouraging, as well as we have decrease in anxiety, depression, cognitive biases, and social and role functioning improvements. We also measured family member empathy as perceived by adolescents, and by their perception, it improved, which was also encouraging. We looked whether family members can successfully learn CBT skills, and yes, they were able to do that. We assessed it via role plays, pre and post, and had independent rater who did not know which role plays were before or after. This was all videotaped. And you can see that they, for example, be able to have significant improvements in ability of empathically respond, um, identify their emotions, elicit possibility of alternative explanations, offering alternative explanations, and overall interpersonal communication skills. We looked at which factors adolescents and parents consider important in treatment. So we ask them to rate um, from 1 to 8 most helpful and least helpful factors. Interestingly, what we learned that particularly adolescents found helping others and being important in their lives, we call it altruism, being a very important factor for them. So being able to actually connect and help others. Another important factor was installation of hope. And through seeing that others had solved problems similar to mine, so group was particularly important. Group cohesion, belonging to and being accepted by a group. So these are main three factors for adolescents. And parents rank universality as being a very important, learning I'm not the only one with this type of problem, as well as group cohesion as well, similar to adolescence, seeing that others had solved problems similar to mine, as well as altruism, helping others was very, very important for parents as well. I'm just going to give you some examples of what adolescents and parents were saying about the program. We interviewed them and asked them about their experiences in order to assess feasibility and acceptability of the program, and also to better understand the impact of the program on participants, and to use this in order to optimize treatment program. And also we wanted to give participants a voice in the program development. So we use semi-structured interviews, we video recorded them, transcribed, and they were coded by multiple raters. So what did we learn? So one factor was ability to cope with negative paranoid thoughts and experience. This was reported by all adolescents and also majority of family members. They also talked about ability to think more positively, increased self-esteem, and increased confidence, particularly in adolescence. Decreased social isolation was important for them. Improved family communication. Both adolescents and family members reported this. Also improved confidence and ability to help their child was very important for family members. Here are some quotes from adolescents. I don't automatically jump to conclusions when people are staring at me. I don't automatically think it's negative. And if I see them talking low or laughing or something, it's probably they might be looking at a billboard, or it might be their own inside joke. So I don't take it to heart. I learned to be a better parent, to be a more patient parent, and certainly to be more understanding about this illness that is very real and very, very terrifying for him. From the beginning of the group, where he was most almost a year barely out of the house, barely socializing, barely doing anything. It's nice to see him out of the house, doing stuff, going places and moving around and feeling good about himself. So here are some comments on program design. We want to know whether the design of program was beneficial and whether there should be some improvements. So our group format provided social support and helped to normalize experience, reported both adolescents and parents. They liked that they had individual session in conjunction, it allows for skill practice and sharing with personal issues, adolescents. Finding CBT more concrete and goal-oriented than other forms of psychotherapy, so they reported that it gave them specific skills, practical skills, and they liked this. They commented on importance of parallel learning because another question was, should we have them learn together, both parents and adolescents in one group, or should we have two different groups? So they like this, having a parallel group, separate group for adolescents and for parents, as they saying it was providing more support and they were able to share about their problems more easily, as well as it was nice because it's a certain developmental stage when they trying to individualize, and it kind of like was in parallel with this process. As they like workbooks, they found it helpful, and also they like a psychoeducational part of it about paranoia, about psychosis, and how to identify um, symptoms was helpful for parents, and also they reported that they can understand their child experience better, which was helpful. Here are some examples. I got to talk about the problems that I had, and I got to share what was going on with me. And when they started what they had that was going on with them, there were a lot of similarities to what I was going through. It found it interesting that I was not alone, adolescent. Here is from parent. I really like the concrete factual information and tools, sort of this are some of the things. This is how we understand it step by step, and this is how we put it together. I also loved the fact that it was a program where the parents and the child could learn the same information. What my child learned, I learned. So I'm able to help him redirect his thoughts if they should go towards paranoia again or anything like this. And here is a couple more quotes from the adolescent. It helped me to understand what paranoia was in general and how it affected each of us individually. We learned what we could do to reduce the effects, to just pretty much say, I'm not going to let this destroy my life and ruin my mind. I'm not going to let my imagination take over. And here is from parent. If you are learning alone and you don't see other people in your situation, then you think you are alone with your problems. But then you see other people, other very nice children, other teenagers that have the same problem, and it's not so scary. It's okay. This is life. Deal with this. These are problems you can solve, solvable problems. To me, it's a great idea to do a group, and a group for adolescents and for their parents. And here is one more from parent. He, my son, learned that things might not always be what they seem, what he has to test, what he sees, and what he believes, and go through the steps to answer those questions. This is what happened to me. Okay, Now, is it reasonable? Is it possible? How is it possible that this happened to me? So I think if it should ever occur again, he will be able work it out in his mind, not to have it as much fear if it happened. Based on the skills that he learned, I think he will be able to reason outward and find evidence to the contrary of what he might be experiencing that may not be based in reality. So in summary, overall, the CBT was well received. We had everybody remained in the study, which is also true for our ongoing randomized control trial. All patients in CBT group completing it. And clinician-administered and self-report assessment shows statistically significant changes from pre and post, which maintained and 3 months follow-up. We see decrease in psychotic-like experiences, paranoid ideation, decrease in anxiety, decrease in depression, improvements in functioning. We also see decreases in cognitive biases and increase in family member empathy as perceived by adolescents. In qualitative interview showed that adolescents found group and individual treatment to be very helpful, particularly in finding people to identify with, share experiences, learn tools, and they show increased self-esteem. Parents found group treatment to be helpful in enhancing communication with their child, feeling more in control to help their child, and also they talk about watching their child grow. I'm going to quickly talk about cognitive behavioral therapy training for clinicians that we have, and this is to train clinicians to be able to administer this program, implement this program in their own settings. So we have 25 hours of didactic activities, lectures, and we also have 15 hours of practicum, learning skills with simulated patient actor, similar how we teach parents skills. And we then follow this by group supervision, which could be 1 hour weekly, and we do it in groups and we do it over the phone. So we will first do brief role plays where clinicians will work with a simulated patients. We have 2 role plays each 10 minutes, and we will then learn about their baseline skills in order to design a better training, personalize it to help them to do what they're already doing best and to further develop their skills. So it's kind of personalized. Day 1, so we have 5 hours. Day 1, we learn about a summary of CBT for psychosis, kind of an overview about theory and research, and then focus on specific skills such as empathic communication, how to ask questions, CBTP specific techniques, how to engage patient who are at risk for psychosis or has psychotic symptoms, how to help him recognize problems, how to help them resolve ambivalence, how to use Columbus style, and how to help them normalize their experiences. And then we do practicum for 3 hours, usually in a group of 6 participants with an actor, where participants will do a very short role play, we videotape it, we give them feedback, and we try it again. Day 2 focused on how to do a CBTP session, how to set goals, how to set up session structure, Then we focus on cognitive behavioral assessment of psychotic experiences and cognitive behavioral formulation of psychotic experiences. Again, we practice with an actor how to do it. Day 3, we talk about cognitive techniques and behavioral techniques specific for psychotic symptoms, and then specifically strategies for delusions and for hallucinations. Again, practicum. And then we also focus on day 4 on CBT strategies for thought disorder, negative symptoms, and how to do relapse prevention. Again, we practice with simulated actor in a group. And day 5 specifically focused on how to run 15 weeks CBT group intervention that I was just talking about for youth, how to teach CBT these skills to families, and also how to conduct individual sessions together with youth and families, and how to do booster sessions. So clinicians will learn how to administer the whole program and how to be a good CBTP therapist. Again, we do practicum, and then we do evaluation again. We do a role play with a simulated patient actor, and then we provide each clinician feedback on what do they do well and what are maybe some areas where they can continue to grow. Just a couple of words about using simulation. So we would do a role play, very brief, usually 2-4 minutes. Clinicians can stop, and then we provide constructive, positive feedback, focusing on strengths, and in the end, we also hear from actor. It gives us an ability to see firsthand which techniques are successful and which are not. Also, ability to go back to a moment in a session and try different approach. Also, ability to work with novel and challenging situations. For example, with a difficult, like angry or agitated patients, how can we do it? And the last thing I wanted to mention is that we are planning to extend this program to a new settings, and we currently are planning a study which has 2 goals: to develop and evaluate early detection strategies for high-risk populations in order to reduce duration of untreated psychosis, and also to conduct a randomized controlled trial of the group family CBT intervention, and to compare active intervention with monitoring, symptom monitoring. So if any clinics might be interested to be engaged in the studies that we're planning, or other studies, or just learn the techniques and implement this program, we'll be very, very happy to work with you. I just want to acknowledge people who really helped with this program. My mentors and consultants. One is Dr. Aaron Beck, who I've been extremely fortunate to work with and consult with, and also Kim Muser, as well as Valerie Reina, David Silbertsweig, John Walkup here at Cornell, and Catherine, Dr. Weike, who is our statistical consultant, and Mark van der Gaag, who implemented wildly prevention and intervention CBTP in the Netherlands, where they have large studies. And also I wanted to thank NIH and Sydney Bear Foundation, who've been funding us. And I would like to stop and say thank you for listening and open this for questions.
All right, if folks have any questions or comments or discussion points, if you just will click the raise your hand icon, I can unmute you and you can ask your questions.
Any questions, comments, anything would be helpful for me to go over? Anything else that you'd like to know, please?
All right, Melissa, you're unmuted.
Yeah. Hi, Dr. Linda. It's Melissa Sminder.
Hi.
And hi. I had a question about early on in the presentation. You were talking about using this for up to age 21, and I guess with this using this model, are there any modifications when you get into that 16 to 21 age range that are different versus the younger 12 to 15-year-olds? Is there anything specifically different?
So thank you. That is a very good question. So we tried it, and now we're doing it starting from age 12. Actually, no. So we tried it. Our youngest individuals are at age 14. We did not happen to have anybody younger than 14, but 14-year-old did very, very well with this. So basically they were able to learn, they liked it. Our characters are very young here, so they understood all the concepts, so we have a very positive experience with younger group. And we extended it to also age 25, and so they did pretty well too, very well. So, and we even had a 14-year-old and a 25-year-old in the same group, which we were a little bit concerned about because such an age difference, but it actually worked out very nicely because the 25-year-old, he shared his experiences, and it was actually nice. They bonded. So, so yeah, so we're finding out that like this is good for like all this age range, and we combine these groups. Any other questions or feedback?
Am I still muted?
No, you're unmuted. So.
Okay. So if the groups are well, I guess the whole program is 15 weeks of sessions each week. Are those groups closed once they start? Because it sounds like from what you shared that each week builds off of the previous.
Yes. So yes, this like this is 15 weeks, and those we did it as closed groups. We're considering having it as an open group as well. So they would, but it worked best if it is. But we did not try it the other way around. So because we had two goals: to create a good bonding experience for both adolescents and parents, and also some of the skills they build up on each other. So they first learn skills and then they apply them. So yeah, so as it is right now, it is closed, but we actually keep thinking about having modules if we can do it. We did not try it, and we didn't do a study on that, so we don't know. But it might be practical also to be able to at least have several entries into the program, but we haven't tried it.
Dr. Landa, this is Connie Cahalan, and I have another question for you as far as, can you talk a little bit about what kind of data pieces, if somebody wanted to be one of the research sites, what kind of data pieces would you expect them to collect?
Thank you for this question. Yes. So if somebody would like to be a research site, what we would like to do is, I'm going back into my presentation, to implement 16 questionnaire. Ideally, we would like to have it both on intake and also administer it to people in the program. I'm just going back here, 16-item prodromal questionnaire. So clinician would give it on intake. If adolescent would have would say yes for 5 questions, then they could be offered to participate in the study. They could be given a choice to contact the study coordinator. We will have a study coordinator. We can actually figure out whether this person could be on your site in Missouri, or we can maybe even do it over internet. We'll have to see. But or if that would be okay to give the information to the study coordinator. So it would take about, I would say, 1-2 minutes to complete this questionnaire, and then just give a flyer and information and ask if it would be possible to give their information to us. From that, we will have a research coordinator doing questionnaires, which would be part of a research protocol, so clinicians would not have to do, on a site would not need to do anything. And then so we're planning it to be randomized. Then we would do evaluation, and then randomization, and we would tell the therapist who would be in their group. And if the therapist would be on a site, let's say people would like to learn this approach, so we would help them to form the group, telling them who would be in a group. A therapist would run the group, and then there will be people who would be in a control group. And we will, research coordinator, will maybe through our site, or maybe we will have somebody we train and supervise in Missouri would administer assessment. That would be part of research protocol. If anything valuable will be discovered through these assessments, we will communicate it to patient and clinicians. And so we will do evaluation every 4 months. So half of people will go to this monitoring and half will go to CBT, and all will go through assessment that we will conduct either through internet or train research coordinator who will be able to do it in Missouri. Yeah, does it, did I answer, or should I clarify a little bit more?
No, I think that's okay for now. I mean, as far as, unless somebody on the phone has some things, we can follow up and get more specific in writing if need be.
So from clinic, basically, we would need somebody administer 16-item prodromal questionnaire, and then if we have a therapist who is doing this treatment, and we can decide whether research coordinator could be on site or could be here, and we could have research coordinator who does assessments be on like, we can decide how to best coordinate it depending on which clinics will like to participate with geographically and what are people's preferences, the way it could work.
And if I was following you right, you said as far as that control group could either be on site at the community mental health center, or you could have a control group at a different site, or where you're at. Did I understand you right?
That's correct, right? That's correct. So it could be either on the same site, then control group, so identify they would only be doing assessments, or potentially we could also do another site be a control site, right? We are, yeah, so we can talk some more about it. So advantages of a control site, being a control is monitoring. So these adolescents would come every 4 months and they would complete all the evaluations. Uh, Patients in our control group actually report this being helpful because answering these questions, making them think that they're actually not alone because other people are also answering these questions. And also if they become worse, if they start developing psychotic symptoms, we can catch them much earlier, basically right away. And if we see that they're not doing so well, we can right away send them to active treatment. Because our goal is to decrease also the duration of untreated psychosis.
All right, we have another question. Katrina, you're unmuted.
Hi, this is Nancy at Kreider Health Center. Katrina's here as well as other members of our clinical team. We have two questions. The first is, what are the credential requirements for the clinicians that would be trained to do this?
That's a great question. So I would say a daily license clinician, it could be a psychologist, it could be a social worker, and trained in CBTP, trained how to deliver that. Do you have any particular credentials that you are thinking about that you wanted to ask about?
No, we just wondered if we thought it probably was a licensed person. And then is the training 5 days in a row, and where is it?
That's a great question. We haven't planned it yet, so but this is a good question. So it could be 5 days in a row. We can also structure it differently. We can break it down, but this is a model that we've been using. Well, it will be perhaps at your site, so we can see how many clinics are interested, how many clinicians we have, and then we can coordinate together and see what would be most feasible. And we're happy to come to a place whenever it would work best for people.
Yeah, it just seemed like that would be pretty intense to do it 5 days in a row.
We can also do it yeah, I'm absolutely open to different models. What do you think might be better? Like, because we can break it down.
Yeah, I don't really have a suggestion. I just was thinking that at 5 days is a lot of information, and it looked like they were long days.
That's right. Actually, so we did not do it 5 days in a row. We, for example, at Mount Sinai, we had it like twice a week over a month and a half. So we had it, for example, on Tuesdays and Thursdays. Tuesdays we had didactics, and Thursdays we had practical. But I'm right here, so it's easy in terms of traveling. Perhaps another model could be coming for 2 days a week. I mean, we can think about it. What could be feasible for clinicians?
Nancy, can you hear me? This is Connie.
Yes.
We can work out the logistics with Dr. Landa. Part of it is going to be cost. I mean, I hear what you're saying as far as having Dr. Landa and her staff come in, but like I said, if people are interested and want to be the site, we can talk and work it out with the coalition as far as what would be the most feasible and how how much money we've got. I mean, we've got a finite amount of dollars, so I concur with you. 5 days is a lot, but we'll also have to work within a budget. So.
Yes, and then, you know, always when I think of budget, I think of lost revenue.
Absolutely. Yeah.
Okay.
All of that.
I think Katrina has. Yeah, Katrina has.
Yeah. While we're unmuted, may I ask another question? Different topic.
Sure.
Absolutely.
Okay. Dr. Landa, thank you for the information. Looking just very briefly at the study, it looked like there were 6 families, all female, single households, all employed. I'm wondering if any of the participants in the study, if the parents also were struggling with their own behavioral health issues, and did that have any impact on their ability to engage and then, you know, translate, kind of also being a CBT therapist in their own home, so to speak?
That's such a good question. So yes, actually the answer is yes. So I'm just going to respond both in this pilot open trial and in the current study, where we have also more fathers participating. We also have both parents joining, but overall there were several participants who particularly had depression and also so struggles with their own mental health problems. Well, they found CBT skills because they're also learning the same skills, so they found them helpful for them as well. But we did not formally measure it, whether their depression improved, although we could. And I would say some of them would find it more difficult to guide their adolescents, and some learn the skills better. And I would think it is also related to their own mental health issues and ways of coping. We were not able to measure it because we didn't have a very big sample, but actually if we do a larger study together, we might be able to better assess it. That's one of the things we can look at more carefully. And then if something additional would be needed for these parents.
Thank you.
That's a great question. Any other thoughts or questions?
This is Connie again, and with DMH. If sites or those individuals listening on the phone to Dr. Landa, if you want to know more about this and I guess are considering being a site, then why don't you email Kim? Is it okay if they email you and you kind of
Yes, that's fine.
tabulate then who, and then
yes,
Kim and I can talk. But yeah, if you're interested in this, if this is appealing to you, if you want to communicate with Kim about this, that would be good. That way we can have it all in one place.
Yeah, that would be wonderful. And thank you, everybody. I'm really delighted to be able to think about it, possibly plan it, and also funded by Bear Foundation, which is in Missouri. So I feel this is really nice to be able possibly to bring this program back to Missouri. So that would be very exciting for us.
All right. Well, I don't see any other hands raised, and we're getting close to the end of our time. Dr. Landa, we just want to thank you very much for your time and sharing this with folks. And I'm sorry, I have one more. Looks like I had one hand raised.
Sure.
Let me see. Nope, no hand raised. It went down. So just to reiterate what Connie said, if any folks are interested in becoming a site or wanting to hear a little bit more detailed information about becoming a site, please email me. We're kind of time sensitive. I know that Dr. Lynn is working on a grant currently, so if we could have responses back to me very quickly, that would be very helpful. And you will be hearing more from Connie and myself on next steps. Thank you, everyone.
Thank you, everybody. Yeah.